Thank you, Senator Sheehy. We're as an organization, very excited to support the frontiers of treatment for difficult things like PTSD and substance abuse, alcohol abuse as well, using tools like psychedelic medicine. What we are trying to do in research is to support this frontier work. I know that Dr. Ilse Wiekers has been here and also working very closely to brief this committee. And for further details specifically on that, I would refer to Dr. Wiekers. But I would say from our research component, our goal is to support the science and support the frontiers, and that's what we're going to do.
I think in the vein of getting the solutions to the field as quickly as possible, we also want to be prepared for enterprise-level rollout of these type of therapeutics, both the care as well as the products themselves. So has there been any thought given yet to lifecycle management, actual rolling out of the novel therapies, training of the staff, and how the logistics of that are going to happen once we get to FDA approval, once we get to VA-wide enterprise approval? Has that planning process begun?
Yes, thank you, Senator Sheehy. We've actually been really thinking about how we translate. And actually, I would say this is not just for psychedelics, but a lot of lines of our research. One of our core goals is how do we rapidly translate that to actual veteran impact? So when it pertains to specifically psychedelics, we've actually created as an organization an integrated project team to think about this both from a science standpoint, but also how do we operationalize this when it's safe, when the science supports it, to better benefit veterans.
Great, yeah, that's good to hear because, as you know, whether it's 22 a day or whether it's veterans paying for their own trips to Mexico or elsewhere to get these treatments, the sooner we can roll them out, the better. And I think the worst thing that could happen is we finish the trials, we finish the double-blind studies, and everything comes out great, and then it's another 5 to 10 years of bureaucratic rollout. No offense, but that's generally how the government works. And in that time, we still have veterans in need. So I think it's just as important as we conduct the research that we also fast track, without cutting corners, the logistics of how we're going to physically roll that out when the time comes. And I think a core component of that will be, of course, our community care networks, which there are existing providers that already do this in the private sector. So we don't have to reinvent the wheel in every case. There could be times where we can leverage that community care network in this sector as well. So thanks for your work on this. Appreciate being here.
Thank you, Senator Sheehy. And I would just say, I think from my perspective, I'm still relatively new, frankly, to the VA. I just joined the organization a little under 3 years ago. But I'm actually a second-generation VA physician. My mom is a primary care doctor at the Erie VA for the last 20 years. So although I'm not a veteran, I've seen and my family has benefited from VA for about half my life. So I understand the value of the organization, what a gem research is at VA, and how it's improved not only veteran care, but American care, and frankly, care for humanity. So that is the pathway and kind of the overarching direction that I want you all to know we have at VA. It's not just me, it's everyone I work with. And I work with so many researchers that are also veterans. And that's such an incredible thing to see. The mission is so important, and that's why we do this work.
Doctor, thank you for your comments in response to Senator Sheehy's question. Senator Bozeman.
Thank you, Mr. Chairman, very much, and Ranking Member Blumenthal for holding the hearing today, and we appreciate our witnesses for being here. VA research has transformed care for veterans while advancing medicine for all Americans. As healthcare continues to evolve, it is important that VA remain a leader in research and innovation so veterans continue to have access to the best possible care. Mr. Chairman, thank you for your leadership on precision oncology and for recently introducing the Precision Oncology Program for Cancer, the Prostate Authorization Act. I especially appreciate your proposal to designate the Little Rock VA Medical Center as a center of excellence for the POPCAP program. Arkansas has built a strong partnership between the Little Rock VA and the University of Arkansas for medical sciences, and I believe it's well positioned to become a national leader in precision oncology and research care for veterans as it has in the past. Dr. Kelly, in fiscal year 24 Consolidated Appropriations Act, Congress provided $5 million to expand the precision oncology program for cancer of the prostate to additional VA medical centers and increased academic cancer center partnerships. It's my understanding that VA instead used those funds to establish a broader precision oncology research program covering multiple cancers. Can you please clarify the VA's view on the POPCAP program and how VA is ensuring the original congressional intent behind the funding has been followed?
Thank you, Dr. Bozeman, for that question. So first, I can't comment directly on the legislation speaking to the POPCAP, but to answer your question, when we were looking at the assignment that was given to us through the Cleveland Dole Act, was passed in 22, about how to manage the POPCAP and the future of that, we looked to our knowledge that we'd gained from other types of systems integration so that we could expand the POPCAP effect across the entire enterprise. So we looked particularly to LPOP, which is the Lung Precision Oncology Program, which was at 114 sites. And we said that that was a good model that we knew worked. That model had done two notable goals that I thought were relevant to POPCAP. One was molecular testing. So for lung cancer, the testing rate had increased most recently up to over 80%, which is higher than pretty much everybody else in the country. So that was one thing. So we noticed that the molecular testing rate was able to go up. And for prostate cancer, the molecular testing rate is still struggling. The centers that are identified in the POPCAP, so there were 14 initial centers that were identified by the Prostate Cancer Foundation, and then VA, in collaboration with PCF, identified an additional 7 to increase the geographic distribution. And so what we saw was that even with those 21 sites, we could expand to over 100 sites, which is what we've done through the CCRN, the Cancer Clinical and Research Network. So that was one aspect of that. And we also saw that LPOP was able to roll out basically from nothing to over 1 million lung cancer screens. So we could impact every place in the entire country. And we thought that was the best model. So that's what we built the expansion of POPCAP on. And that